I'm going to go through a case, and during this case, we'll kind of highlight what I think is some good diagnostic workups and then management of these complex cases. Just by way of disclosure, I am a medical education consultant for Stryker, and I'm going to show some x-rays of some Stryker implants. So it's a 57-year-old female. She was a skiing in Switzerland, and she had a tibial plateau fracture. She had an ORIF done there. And then over the years, she began to develop right knee pain, mostly on the lateral side and a significant limp. And she's failed all non-op management. George and I share a floor, so a thorough, exhaustive workup like you guys can imagine. So she comes to us with these types of x-rays. She also has this skin incision. So 2 incisions, they went in there, they did the appropriate management. They didn't do the dead bone sandwich, which we see, which is what we usually see. So now you can see clearly we've got a couple challenges here. So not only the challenges are what to do with the bone, but also the skin management. So I'm going to go through step by step, and we'll get some of the panel's thoughts on what do we do here. Bolo, any further imaging you need on this patient? You've got the x-rays. Did that tell you enough? Or are you going to get anything else?
I think I'm okay with the x-rays only, baby.
Brian, same thing?
Yeah, I think the same thing. I'm not, she's far enough out. I'm not too concerned about healing or having a big non-union over there. So I'm happy with just plain x-rays on this case.
Yeah, I think that's a good point. Sometimes these are, we see them within 3-6 months where you might be concerned about fracture pieces not being united. Then a CT scan might be helpful. Any type of infection workup, Matthias? Post-traumatics?
Obviously, what I'm most concerned about is those skin bridges. And the question is, do you just go in and take out the plate first? In terms of infection, there's been plenty of studies show that even plates and screws that look benign actually will, if they're ultrasonicated, actually have bugs on them. So certainly with this amount of hardware, these 2 incisions, high energy, I wouldn't hesitate to take out the hardware first and culture that. And then obviously my concern is the skin bridges, and this is where I certainly get plastics involved earlier rather than later.
Yeah. Bo, would you get ESR, CRP, aspiration on this type of thing?
You're muted, Mike.
Yeah. So, I think I would say hit or miss a little bit, not 100%. I think we're really good about making sure we do it on all true revisions, but probably I would say I'm not 100% on these hardware cases.
What if it was an open fracture that required, nailing or something like that?
Yeah, no, and I would say I'm sort of more conceding. I've probably missed getting. I would support getting them, but I think I've probably missed getting them on some of these cases.
The one thing, Jonathan, I do for these cases is I delve into in their post-operative recovery. Because you ask the question, well, did the wounds heal well? Well, someone will say, yeah, no problems, or yeah, well, they said I had a little infection, or I was on antibiotics for 3 months, or that sort of thing, and those are sort of big red flags. And simple history can get you a lot of information and sway you to get that sed-rate CRP and aspirate it, and certainly any history of use of antibiotics, I will take the hardware out first in a staged manner. Obviously, patients don't like that, and doing separate operations is no fun.
Yeah, it's always shocking to me when somebody comes in and said they had surgery, and then you probe them a little bit and they said, oh yeah, well 3 days after I went back to the operating room because I had, the wound was draining, and then I went back again. It quickly spirals from there. So, all right, staged hardware removal. Brian, are you taking out the plates and screws, or are you just taking out what's in your way?
Yeah, it's a great question. So I would say that in most instances, I try and do everything in one surgery because I think there is some morbidity of taking patients back a couple times. As Matthias mentioned, if there's any concern about infection, some would argue just for wound healing, take the hardware out, let the wound heal, and then come back. that you could argue to do it staged, but my general preference is to try and do it in one surgery if possible and just take out the hardware that's in the way.
I agree with that. That's certainly my overall approach. But, suddenly with the 2 incisions and there's a lot of screws. It's not just a plate with some screws. All those screws coming from medial to lateral get me a little bit concerned.
Yeah, same. What worried me here was just the sheer amount of screws in the metaphyseal area. Needed those removed. What incision are we going to use here, guys? Now, we've got these 2 big incisions. You want to go straight up the middle and ignore them, use just the lateral one, maybe just the medial one? I mean, when do you get plastics involved?
So, I think Matthias said, get them involved early, even if you just have them look at it, ahead of time, just to show that you're thinking about it. And if you do run into issues, the general rule is to use the lateral most one if you're worried about the skin bridge, which is what I have always favored doing, and just creating a full thickness skin flap. I mean, it's not necessarily benign. Oftentimes those patients end up with some edge necrosis, and how you curve the incision around and making sure you're making that flap really full thickness. That's generally been my preference, rather than trying to go midline or medial and praying that I don't get a skin bridge necrosis.
I think one of the advantages of having plastics involved early, it lets the patient know that this is not just your garden variety knee replacement. And they sort of, you put up the flag that, guess what, this is not straightforward. You may have a problem, as opposed to, 2 days or 3 days after surgery, there's a necrotic skin edge, and they go, well, why didn't you think of that beforehand? If you get a necrotic edge, at least you have plastics involved right from the start. Patients knew it was going to be a potential problem. There's no surprises. I think even just purely medically, legally, you're in better shape having them involved early, as opposed to trying to play catch up.
Yeah, this patient would see plastics probably first, separate consult. We have a team of our plastic surgery, I guess you'd say colleagues that we work with the most. And so they like to see them. I think it's nice. They like to see them pre-op. So it's a separate visit for the patient, but I agree with what Matthias says about it sort of heightens the sense of awareness of what's coming up.
Yeah, this lady especially, I mean, she's got a skin thinny leg. The skin is very thin. There's not much subcutaneous tissue. This is a high risk type of situation. So I went ahead, we took out the plate and screws first. We did it in a staged fashion. She had no problems healing that other incision. We took some bone biopsies just because we were there. So no evidence of infection at all, and her ESR CRP were completely normal on that. Got the CT scan, and it showed some defects. Really, it doesn't seem like it's that difficult to manage. Maybe a 2A defect, but overall it wasn't that bad. She just had a little bit of valgus alignment, 5 to 10 degrees. I did this with some technology guidance. I thought the pictures would really highlight what was going on here. If you put your tibial tray in the right position, you can see she's got basically a 5.5 millimeter defect there on the lateral side. What we've learned in the past, 5 millimeters or less, you can fill with cement and not worry about it. Anything more than 5 millimeters, start thinking about metal. Anything concerning here, Brian? Or is this just a straightforward, cement, maybe some screws and cement? Or
Yeah, so I think it depends on the location of the defect. Oftentimes these patients are, number one, they're stiff. It's interesting from a balancing perspective. Sometimes these actually aren't as hard to balance because they haven't been valgus their whole life, and they haven't gotten that scarred lateral side and that loose medial side. So sometimes because it's mainly just a bony defect, they balance out pretty easily. If it's centrally contained and you have you have just a central defect and a nice peripheral rim, I think screws and cement work great in this situation. A little rebarb centrally, and plus or minus, I might add a little short stubby stem on this. This is probably someone I would obviously go cemented. I probably wouldn't do cementless on someone like this with defects on the tibial side. And if it was bigger and uncontained, plus or minus an augment. But I found screws and cement work really good in these cases.
Bolo, any role here for a cone, sleeves, anything like that?
Well, I mean, I think it's going to be okay, like Springer said, with a sort of screw and cement. That's probably what I'm leaning to. I mean, I think it's great to have it in the room and available, but I think you're okay with stopping short of it.
If there was any doubt in terms of bone quality, what Brian mentioned in terms of putting a little stubby on there, I think it never hurts to do that. It just gives you, and she's thin, but any hint of being a little bit heavier, I would absolutely go with a little stubby stem and cement it the whole way down. It's insurance.
Good. So I guess what I'm hearing is treat it basically like a primary, except if you're worried, and then go up one level of constraint. Just one thing I wanted to highlight, Seth Drobeck taught me this. You can use the robot and kind of fake like you're going to cut an augment. So bring the tibial tray down 5 millimeters, and you can cut an exactly perfect lateral wedge for the augment using the technology. So if you are prone to using this technology, that's a cool little trick that he taught me. We didn't need to on this case. You can see once we put the implants on there, there was a very minimal augment that was left there. But the real problem came when it was with her bone quality. That bone did not heal very well. It was all this fibrous bone, so it ended up with a huge lateral defect with only a thin shell of cortical bone. So even though the CT scan looked pretty good, it was a lot of this fibrous kind of trabecular bone. So I ended up putting a cone with a little bit of a lateral flare on there. Short cemented stems just to protect it on the femoral side was okay. So like Brian said, pretty easy to balance her back. She was a little bit lax on her ligaments, so I used a constrained poly on this. Any thoughts on this reconstruction, guys? Overkill, maybe?
You can't argue with biologic fixation.
I don't think it's overkill at all. I think it's just, the extent of the defect probably dictated what you sort of had to do there, what you described. And so, no, I think it looks wonderful.
There's a question in the chat room about proprioception in these fractures. Jonathan, any thoughts, or Mike or Brian? Yeah, that they're with high energy.
I read the text. That's actually educational to me. It sort of makes sense. I still would probably make an intraoperative decision about constraint use, but it's a good thought.
Yeah, I mean, I think we have so many options in terms of constraint these days that you don't have to go to the most rigid CCK type design. You can go from, I don't think anyone would probably do a CR knee here, but there's PS pluses and a little bit more constraint than the standard PS, but you don't have to go to the most rigid CCK design either. So I think we have lots of good options. And it's a game day decision, I think, intraoperatively.
Well, things I wanted to touch on your intraoperative protocols. Anybody doing an iodine wash, chlorhexidine wash in these post-traumatics? Or maybe all patients or higher risk? Thoughts on that?
I do a dilute betadine in all patients. I actually do betadine peroxide combined in all patients.
I do betadine peroxide on high risk patients, all revisions and certainly removable hardware.
Yeah, this would get it, JB.
Yeah, Vanco powder. Anybody sprinkling some pixie dust in the wound?
Guilty as charged at times.
I'm not going to say never. I just, every time I say we did publish this one study that it's not perfect. It's retrospective, and I think it's all primary hip, but it's out of Duke Regional, one of our affiliate hospitals, and it actually was worse. Our infection rate was worse putting it in there. And I'm sure there were other variables, but we tried to control for all of it. So I don't know. Less and less.
Well, you're in charge of the antibiotic stewardship with maybe one dose preoperatively, so I think that may be the right message. Yeah. Clinical-wise, nylon sutures, subcutaneous, subcuticular. Mike Taunton published on sub-Q sutures, less tension on the wound. Anybody? Or staples? Anybody?
Again, I probably have plastics.
Yeah,
plastics. Good.
Negative pressure wound devices. Jonathan, in terms of negative pressure dressings, if you think about it, put it on. It's one of those. You think about compartment syndrome, you measure it. If you think about that you may need a negative pressure dressing, yeah, it costs a little bit of money, but the downside is none.
Yeah.
Perfect. These are very prone to being stiff, like you guys mentioned. Anybody going to put her in a knee immobilizer for a couple of days to protect the wound, or start CPM to get the motion back, or just kind of do what you normally do?
Yeah, I don't see any role for CPM. If I was really worried about it, I may keep her straight for a few days just to make sure she doesn't get it, have any drainage or necrosis that we're putting tension on. But probably not for a prolonged period of time.
Yeah, I agree. Again, it sounds like we just are doing down here less and less, but, we don't initiate PT actually anymore for the first 2 weeks. So that's, people can get it, but we've stopped formal PT for knees for sure for the first 2 weeks. And hips.
I tried doing that for my hips a couple of years ago. The New Yorkers got yelled and screamed at me that I didn't give them PT. So,
well, we're less educated down here, Matthias, and so we can just, no, but I think that's the wound protection, right? So like Springer said, I don't know about formally doing something, but if plastic, a lot of times plastics will tell us knee immobilizer and extension for 2 weeks. So that may dictate it.
Yeah. Jonathan, why don't you move to the didactic portion? We're running a little behind.
We'll do so. We built in a lot of the didactics in the talk there. So post-traumatic arthritis, 1 to 2% of this. The prevalence is really 21 to 50% after these injuries. So they're quite complex. As we talked about, soft tissue problems, previous injuries, stiffness and range of motion is a huge problem here. And then you also have some rotational malalignments that can give you some intraoperative challenges. The Mayo group looked at this, and this was an update from their previous JBJS paper, but basically found that we are making these people better. Their knee society scores and functional scores do improve, but they have almost a 20% revision rate. Most of those were aseptic loosening or instability, but complication rates were significantly through the roof. Stiffness, wound breakdown, infections, subluxations, hematomas, you name it, they were seeing it. So a very difficult group of population of patients. Another paper out of Mayo, same thing, 500 patients, 11% revision at 4 years, infection, instability, loosening, and stiffness, same types of things that we talked about. So doing a lot of the stuff that we discussed with good fixation, good antibiotic management, maybe antibiotic cement, betadine washes, things like that to keep you from getting these top reasons for revision are really important to focus on. Revision-free at 20 years, 67% in the post-traumatic group, significantly lower than their OA group. And infection-free survival also significantly lower. So odds ratios of an infection, 2.3 for superficial, 3 times the odds ratio of a deep infection. So very difficult patients. I think we need to think about potentially prolonged antibiotics, potentially antibiotics in the cement, all the washes, all the things we're doing. BOLA published a paper here too, looked at the Medicare database, looking at CMS complications, 90-day surgical complications, increase in INDs, cellulitis, infections, mechanical complications, and wound complications. I'm harping on this because this is a complex group of patients, and we have to do everything we can to kind of prevent these. So, like I said, total knee in the post-traumatics, higher complication rates, higher infection rates, more transfusions, longer surgical times. Do what you can. A wound vac, it may be more costly, but these patients are more costly over time. So if you can prevent an infection in these patients, it might be worth it. So thanks for your time.